Hello everyone, and a very warm welcome to this simulation and case-based learning session. It's wonderful to see so many of you here. Thanks for filling the room. You've made a good decision in coming to this session because we've got a real treat for you. I can say with some confidence that this is probably one of the most complex events ever attempted. So we've got a fabulous panel behind me who will be showing off their skills with the various sessions that we have planned. So what we want to talk about in this session is the EVOQUE and the PASCAL Precision sessions, and we want to show you them in action. The important features that we consider as implanters, as imagers, is accuracy. So we're often handling focal pathology with small valves. You need to be very precise and very accurate. Versatility is hugely important given the complexity and heterogeneity of the disease that we treat. Safety is all of our #1 priority. We want to make sure that we don't do damage in any of the procedures that we do, and we can optimize as much as we need to without causing any trauma. None of us like surprises. We all want predictability of release. When we make our grasp, when we then release, we don't want to see a change. Finally, we're going to look at the EVOQUE system, which has the potential to completely treat tricuspid regurgitation. So we have a really exciting session lined up for you today. We're going to focus on all of those features with our panelists, and we're going to finish with a EVOQUE session, EVOQUE deployment from start to finish, which I'm really looking forward to. What makes this session is the audience. So interactivity is hugely important. You may not have seen these before, but these are microphones. I'm not a gifted thrower, so I'm going to hand over to Volker for that, so we can pass them to you if you have any questions. Just be nice and close to that when you send your questions to us. This faculty is amongst the most experienced in the world at these technologies. Please do make the most of them. So we'll come round, we've got roving mics, we've got the boxes. Please do ask questions, please do interact and make the most of the people that we have here. For each of these sessions, we'll spend 10 minutes or so on a scenario with a pair of operators and imagers, and then we'll have a couple of minutes for discussion. I'll just hand over to Volker to talk through some of the interactive aspects.
Well, thank you, Sam. Thank you so much. And I'm of course also thrilled to be part of this session. It's really exciting, I can tell you. I mean, I think the main purpose of this is to bring all these procedures as close as possible to all of you. So please use these microphones as much as you want, interrupt us at any time so that we can interact. If there's anything you can't see, you don't understand, just tell us. For the people at home who are watching us, we have the app, and we also ask to use this to have really an interactive session here. So, and I think with that, we are ready to start. Indeed.
Let's make a start. So we're going to start with Maurizio and Federico. So if you'd like to step forward. And in a second on the screens up there, you will be able to see an operator perspective camera, you'll see echo, and you'll see a boroscope. So you'll be able to see exactly what they're doing. Federico, over to you.
Thank you.
The chairs came.
Okay, so I think we can jump straight into the case and see the first patient. Then Maurizio is going to show on the simulator what we have done. The first case is an 84-year-old female, symptomatic for severe shortness of breath, New York Heart 3. You see the problem. She has a good LV function and a significant severe mitral regurgitation with a mildly dilated left atrium, mild tricuspid regurgitation, and a near normal pulmonary artery pressure. On the 3D images, you see clearly the lesion, and the cause of the severe mitral regurgitation of this lady is a P3 prolapse, which is quite commissural. There is some sort of indentation in the mid of the posterior leaflet, but no color jet was coming from that area. There is probably a chordal rupture. You see under the red arrow some sort of cord coming up above in the left atrium. The mitral valve area is quite large, 5.9 square centimeter, and the baseline transmitral gradient is 3 millimeters of mercury. This is her pre-procedural transesophageal echo imaging. You see very clearly a posteromedial commissural jet with an anteriorly directed jet and a severe mitral regurgitation. We have some challenges when we think about treating this patient. It's a P3 prolapse, so we are close to the septum. We need to be very accurate with our transeptal puncture. The lesion is commissural. It's an area which is dense with chordae, so we need a precise navigation, and we have some mild fibrosis of the posterior leaflet, despite it being a long leaflet, and so that should pose no problem. We want to have obviously a precise device. We want to achieve a commissural positioning, maybe an 11 to 5 clocking for the device. It's a bit too extreme in the image. We need a responsive system, and we have to be obviously accurate in the positioning in this chordal death area. So we chose to treat the patient with a PASCAL Precision system with an ACE implant. Maurizio.
Thanks, Federico. Actually, this is a typical case where to be accurate, precise is mandatory. We will try now to show some of the features of the PASCAL Precision on this simulator that are actually extremely useful to treat cases like this. We will show this on a tricuspid valve because, I mean, as you may see from this model, exactly, you see it now, this is a tricuspid valve, but for the purpose of what we want to show, tricuspid is probably even more adapt because, I mean, we need to be extremely accurate and precise also in tricuspid. Few words regarding this simulator. You may see it's a beating heart simulator. It is not a human heart. Obviously, it's a porcine heart, which is not exactly the same, but in terms of atrioventricular valve anatomy, it's pretty much similar to the human one. You may see here a tricuspid valve from above. So this is the atrial side. This is a surgical view of the tricuspid valve. It's not the surgical view that we usually showed when you do 3D echo. This is the real surgical view, where the aortic valve would be more or less at 9 o'clock, so on the left part. You may see that the heart is not complete. There are no vena cava. The two atria have been removed. There is no septum. And the camera is looking from let's say, the atrial face. So these are somehow the setup where we are going to demonstrate how it works. Also, the aortic valve has been removed. So in the echo, you may not see the aortic valve as in an unusual case. Giulia is now showing us the echo is a transesophageal view where we have the RV inflow view on the left part. And then explaining, we have our grasping view where we have on the left the septal leaflet and on the right, in this case, anterior leaflet, but let's say the lateral leaflet. You may know the device. Obviously, the device for tricuspid is exactly the same as for the mitral. It's composed of 3 components. There is the steerable, there is the transeptal guiding sheath, then there is the steerable, and then there is the implant catheter. There is no locking mechanism, so we can manipulate the 3 of them in 360 degrees in order to achieve whatever trajectory we want. And in some specific anatomy, this is a big advantage. You may also know that the PASCAL Precision is extremely easy to use, also due to this stabilizer rail, which is almost allowing to perform the procedure as a single operator. Actually, it's nice to be in 2, but it's so stable and so predictable that as a single operator is definitely feasible. Few words regarding how the catheter behaves in tricuspid. You may see that the 3 catheters are stabilized by 3 different components, and we can move them together or so simultaneously or one by one according to what we want to do. You see now that the catheter is already above the tricuspid valve, so we are in the right atrium. And you may see that in front of us, there is the anteroseptal commissure, which is going to be the target of this demonstration. So if we push all the system in, we go closer to the commissure. So now I'm navigating above the anteroseptal line of captation. If I push everything in, I go close to the aortic valve, which is missing here. But I mean, in the RV inflow, we go closer to the aortic valve. If I pull everything back, I actually go more central, so more far from the aortic valve. Then, if I manipulate the steerable, I can do this movement. Obviously, I can go clockwise, and this will swing our catheter toward the septum, so toward the septal leaflet. If I move counterclockwise, I go lateral, so in this case, toward the anterior leaflet. And this is used basically to swing in our grasping view the device. If we flex the steerable, you may see that the curve in the RV inflow change. So I can, now the trajectory is already quite okay, so coaxial, but we can oversteer or unsteer. Basically, the concept as for the mitral is that we want to have a coaxial trajectory in both the plane of the X-plane, so in the RV inflow and also in the grasping view. If you are not happy with the trajectory in the view to capture the leaflet, we can actually use the steerability feature of the transeptal guiding, which brings us far from the septum or closer to the septum. So if the inferior vena cava brings us close to the septum, where we have the so-called septal hugging trajectory, we may correct this by steering more the transeptal guiding far from the septum. Last but not least, there is obviously the implant that we can advance towards the valve once we have nice trajectory. So in this case, as said, we want to be in the anteroseptal line of captation, and we want to capture the septal and the anterior leaflet. Once you have nice trajectory, like in this case, you may open the device and you may see in the grasping view now the device open and check the clocking. Mandatory is to be perpendicular to the line of captation. And one of the amazing peculiarity of Precision is that the response between what I do here with my hand and the clocking of the device is almost one-to-one. So you may see in the camera that even small clocking is translated to one-to-one device change of the clocking. And now you see in the grasping view, we have the pedal open, the clasp are ready to be tested. We can obviously test independently the clasp. There is two color, but there is also tactile feedback, so I don't need to look at my hand, I can see what is what. And I check again the trajectory. It's extremely interesting to see that how stable it is. It doesn't change, so I'm advancing and pulling back, and you still see that the clocking of the device is not changing. Now we would be ready to cross the valve. Obviously, we do this by closing, but I think it's now time to check what Federico did in the real case, and which is a mitral, so we come back to mitral, but actually use the feature that we showed in the simulator.
Yeah.
So thank you. In the meantime, are there any questions with regard to steering of the device? Can we maybe get a glimpse of who already used the system? Just
Yeah, so who uses PASCAL in the mitral position? And who uses PASCAL in the tricuspid position? Okay.
Okay, so let's see what we did. Here is intraoperative echo imaging. You see we adapted the trajectory in the intercommissural and in the with an X-plane in the three-chamber view. Maybe we were a little bit too aorta hugger, which we didn't correct in the first place, because in case of posterior prolapses, this might ease capturing the posterior leaflet. So this was the first position that we attempted. We set the clocking as we planned on 11 to 5, being close to the commissure. We advanced, we got the leaflets, and we still had some unacceptably significant residual MR2 plus jet coming between the implant and the commissure. So this is not the position we wanted. We needed to reposition the device. So we released both leaflets, and again, exploiting the precision and the flexibility of the PASCAL Precision system, we pushed a little bit more closer to the commissure in order to have no residual jet between the implant and the commissure. We had a very tiny, very minimal and totally acceptable residual jet lateral to the implant. You see, we also corrected the trajectory in the three-chamber view in order to be more perpendicular to the mitral valve plane. At this stage, we released the device. We had a very tiny jet lateral to the device, no residual jet medial between the device and the commissure, and this was our final result with a transmittal gradient which was unchanged as compared to the baseline. Thank you.
So that's a great example of the difference that a very small movement can make. We've all seen that, where you have a result that really isn't acceptable and you tweak a couple of things, tweak the trajectory, tweak the orientation, and you end up with a result as excellent as that. So a very nice job there. I suppose a question for the audience: how comfortable do you feel repositioning? So you've got your grasp, and it's you may be able to do better, you may not. How do you feel about opening the device, moving it, changing the orientation a tiny bit? Anyone happy to answer that question? I'm going to pick on people I know to start with, I'm afraid. So how do you feel, Saib, about repositioning? So you've got a grasp, you've got a good grasp for both leaflets. The MR or TR is a bit better, but you think you can do better. Stick or twist? That's the question.
Yeah, it is difficult, isn't it? I think after assessment, actually, you've got to make sure that you're not compromising the case. So getting stuck in calls, repositioning. But I'm quite comfortable with that. I think if there's more in a case like that, it made a massive difference. So I think it's being comfortable and taking your time. The imaging is absolutely crucial. So really making sure you've got that good interaction and relationship with your imager to really assess it properly. And I think sometimes just taking a bit more of the leaflet in, or just changing, as you say, just the angle, because often we just want that perpendicular, but in fact 11 to 5 there made a big difference, and just pushing it out a bit more lateral made a big difference. His commissure was always worried you get stuck and you can't get out of it, can't you? And I think, but I think it's making sure you get the balance right without compromising the patient.
Yeah, it's the line between perfectionism and pragmatism. It's always a difficult one. So another point that was made very, very eloquently by Maurizio at the beginning is the importance of setting the trajectory and doing that before anything else. The temptation is to go for the position, so to decide where you want to grasp, but actually get the trajectory first and then go to your position, and then you'll get a nice grasp without distorting the leaflets. Any questions from the chat so far, or should we encourage people to contribute?
Yeah, absolutely, but so far nothing. So I think we can go on, right, with the implantation.
Thank you.
Okay, thank you very much. So we're going to hand over now to Rob and Ealing, our friends from London. So they've got another case to present us. So give us the background.
Great. So good afternoon, everyone. So we're going to take you through a 76-year-old female who we assessed with NYHA class 2 breathlessness, lower limb edema, with a gradual but progressive reduction in her exercise tolerance. Probably quite a typical patient we all face on the background of severe tricuspid regurgitation in the context of permanent atrial fibrillation, previous failed DC cardioversions, hypertension, hypothyroidism that's treated, as well as a historic gastric ulcer. You'll see there from her medication list, she's of course anticoagulated with apixaban, but in terms of her diuretic requirements, only on furosemide of 40, and her NT-proBNP was significantly elevated at 2,164 in the context of the tricuspid regurgitation. Here are her transesophageal echo images. So on the top left-hand image panel in a transgastric view, I think we'll all agree she has significant tricuspid regurgitation, primarily centrally, but also extending towards the anteroseptal commissure a little bit more, but still some TR within the postural septal segments as well. You can appreciate the right ventricular function on the 4-chamber 0 degrees view in the bottom image panel. Her ventricular function was reasonable in the context of the right ventricular volume overload. And then looking at our working views on the right-hand image panels, you can see there's certainly a very broad jet of torrential tricuspid regurgitation, starting anteriorly and then extending across posteriorly. So here are more representative views for what we usually use in terms of a systematic approach to considering edge-to-edge repair on the tricuspid valve. The RV inflow views on the left, the corresponding X-plane images on the right in terms of our grasping views. I think we can all see that there is some leaflet restriction, particularly of the septal leaflet at the tips. But in terms of the leaflet lengths, certainly nothing that would be obviously prohibitive for consideration of edge-to-edge repair. So just to summarize her transesophageal echo findings, she has a quadricuspid type 3B tricuspid valve, coaptation defect as mentioned. In terms of quantitative assessment, her tricuspid regurgitation falls within the torrential range in terms of the effective regurgitant orifice area, the regurgitant volume, and of course we see hepatic vein systolic flow reversal. There's active RV systolic function and no significant left heart hemodynamic pathology. So in terms of contemplating tackling this valve with edge-to-edge repair, we could certainly think about the strategy, but certainly from anatomical points of view, we certainly need a versatile implant that allows us to traverse often quite complex anatomy, as you can see there from a dilated RV from a morphological perspective. There's certainly multiple sources of getting entrapped. Not demonstrated in this case, but important to consider given the large number of pacing-related or pacing-associated tricuspid regurgitation cases that we may face. That also lends to the importance of versatility. With that, I'm going to pass over to Rob.
Ealing, thank you. I think it's interesting that slide, the image of the cords. If you could see those cords when you were doing these procedures, you probably wouldn't do these procedures. But I think that really lends itself to the argument about how important this system is. The cords are something that worry us. Getting caught in cords is something that happens, and it happens more on the tricuspid side than the mitral side. And that's one of the things I'm going to show to you, hopefully, in a second, how versatile the system is and its ability to elongate and get yourself out of most trouble. You're going to have to use your imagination here to see this valve. And imagine that we have a large coaptation defect really along the entire septal leaflet between the septal and anterior, centrally and septal and posterior. And we're going to attempt to treat, starting probably halfway up the anterior leaflet and its coaptation with the septal leaflet. So we've already seen, we've tested trajectory, we've tested our clasps. We're sitting here in the middle. One of the things that I do when I cross the valve, I don't tend to cross necessarily in exactly where I want to treat. I tend to cross centrally and then move the system either in or out, anterior or posterior, once I'm in the ventricle. We're actually in a fairly central position here. We're fairly close to where we're going to treat. And so we're going to start off by taking the system, the implant across the valve.
So anterior and septal is the most common. I won't interrupt you. I'll just keep
you're
talking
fine,
while you're going. But anterior and septal is probably the most common place that we'd start, right? And that's because that's where the pathology usually is. But also it's furthest away from the TOE probe. So you want to start there and work your way posterior.
One of the things that I always think is that despite you checking the trajectory beforehand, it's always possible. Let's imagine you're crossing in the commissure. It's always possible that it dives a bit anteriorly, in which case you're suddenly into the anterior cords. So I would always cross away from the commissures in the center or to the posterior edge of the anterior leaflet. We do this with two people. We do it with two people deliberately. One person takes the device, the implant across the valve. And as they're doing that, the other person is mindful that perhaps it's diving septally and it needs to come lateral. Perhaps there's too much flex on it, it's going posteriorly, in which case take some flex off. So we're taking our implant across here. You see nicely seen on the right-hand image. Okay,
perhaps just to orient people, because we have some fairly new tricuspid operators in the room. The left-hand view, although it's tricuspid, just think of it like bicommissural. It's an RV inflow-outflow view, but the movements are the same, right?
Exactly. I mean, for us simple interventionalists, we have to have reference points, don't we?
Absolutely.
So this is the bicom and the X-plane grasping view from the tricuspid side of things.
And the left-hand leaflet in the right-hand view is always the septal, and the right-hand leaflet depends on where the X-plane is.
Well, we just say other.
The other one,
when we don't know. Okay, so we're going to open. Remember, it's always worth when you open, you'll become deeper than you started. Okay, so we're just opening the implant there. Okay, now. Quite deliberately, we've done this, we've gone deep. And this is one of the things that we're trying to highlight in reference to our case, is that we've gone deep, we've gone into the cords, and we're going to imagine now, again, you have to extend belief, we'll imagine that we're entangled in the cords. And you often see this, fluoroscopy is so important to this case. you will see straight away when you're caught on something.
You see an odd movement, don't you?
You'll see the odd
it's
movement.
catching.
You see the just the deflection of the tip of the catheter. You see that you've got tension on the system that you shouldn't have. And in that situation, this is again that versatility of the system. We are able to elongate. What that means basically is opening further, opening into a fairly sleek system.
Yeah, and if you look at the right-hand echo view there, you'll see the device becomes essentially a straight line with no sharp edges, and then you're not going to get stuck.
Yeah, and it works. And it really does work. It's one of the things that we really like using this. You see how it's moved there. It's moved there because it was probably caught on something in the ventricle. And what that means is it enables us then to pull back and to come into safety and then go back to capture ready. We're not going to do that on this occasion. We're just highlighting how useful that is. So we're going to close to what's called capture ready. And capture ready basically is your paddles out in 180. Okay, so you can see there we've got a sort of flat tabletop, as it were. We're going to check again here our alignment. Not quite so easy to see on this image here, but you can probably a little bit of anti-clockwise. You want to be nice and perpendicular to the line of coaptation of the leaflets. Now you see already, we're deep in the ventricle, but you can see already that the anterior leaflet is just about interacting with the device. So if we swing laterally, and this tends to be the lower leaflet, we tend to grasp
usually that one first,
the lateral
right?
leaflet first. Okay, so we may be actually, there we go. We were caught on the, see how easily it is to become, to interact. Can't quite see the arm, there we go. Okay, so if we come back there, I don't remember I didn't see which one was the anterior.
Rob's blaming his assistant already.
Okay, it's that one. So you see, I'm pretty sure it's that one, isn't it? You can see how we've got so much of the anterior leaflet, it's not moving. What we like to see is we like to see the clasp bouncing up and down on the leaflet. So we've definitely got a good chunk of anterior leaflet there. We might have too much. And this is important. This system is much more supportive, much more able to swing than the old system. But even so, if you get too much anterior or other leaflet, it's often difficult then to swing back to make sure you can get underneath the septal leaflet. So what we're going to do, we're going to just go a little bit lower to make sure we get underneath that septal. See how long that septal leaflet is. And we're going to swing septally and come back. Now, I don't like the look of that because you see how the tip of the septal leaflet is pivoting, is just hinging at the tip of the device. We don't want that. We want that leaflet into the hilt.
And that's very typical of real life, isn't it? The septal leaflet is often tethered and curled, and you often see that appearance. And you can just go a little bit deeper, fine-tune a little bit deeper.
I mean, it's still probably...
It's starting to open out onto the paddle, isn't it?
One of the things you can do, I think this is a very atraumatic system, and one of the things you can do is you can drop your septal.
Looks more reassuring, actually, now.
It doesn't look bad, does it? You can drop your septal. I think we're probably slightly out of plane there, Julio. Are we just... No? Oh, all right.
Blaming the imager now.
Imagers are all the same. It's always our fault, isn't it? I'm only saying that because I can't see the clasp on the anterior leaflet going up and down, although we were pretty happy that we got it. What we're going to do is we're going to take off our tension here. We're going to neutralize. And what we often do in this situation is we put color on. There's no color here because there's no regurgitation. And we close on color to show. Now, I tend to do that with color compare. I like to see the 2D grayscale images, but I also like to see the color go away. If you can reduce color, it's a pretty good sign that you've had a good grasp.
But you definitely want to see the interaction with leaflets as well.
But you want to see the interaction.
The color compares are nice.
Exactly right. So we're closing there. What we can see is it looks like the septal leaflet is pretty short. Think about how long that other leaflet, the anterior leaflet, was initially, and compare that to what we're looking at now. Now, we're not going to do anything here until our imager has said, look, I'm happy. And what we often do is we often open to show that clasp bouncing. We often open to sometimes we will lift a clasp to be certain that we've got leaflet into the hilt. As an example here, we don't often optimize the anterior leaflet because if you optimize the anterior leaflet, usually because it's so much lower than the septal leaflet, you will just lose it. But on this occasion, should we optimize anterior? Okay, the grasp is ideal. I'm not going to... I was told to do this, which is why I'm optimizing the... and I do as I'm told, mostly. Okay, so we're quite high up here. You see the way it's hinging. So what you can do, again, I've forgotten which one it is. It's this one, isn't it?
Yeah. Very nice.
Okay, so look at that. You can see leaflet, Sam Ealing, you can see leaflet going into the device.
Going right into the apex, actually.
Yeah, exactly. So let's put it down again.
And you sometimes feel, why am I doing that? What if it falls out? But the answer is, if it falls out, you didn't have enough.
You can't get more than, in theory, you can't get more than leaflet into the hilt. And if you're getting more than that, you're bunching it up. So I think that's probably as good as we're going to get here. So if we just focus back on our device, okay, we've normalized and we've closed here. And again, we're going to assess this in detail to make sure that it's made a difference. There's no point putting a first device in, except in exceptional circumstances, if it doesn't make a difference to the TR.
Great. Thank you very much.
What happened next?
Thank you so much.
So back to the slides, please.
So we do have one question from the chat here, and I'd like to direct this to Robert Smith. And I think you already nicely illustrated this, but this specifically refers now to the mitral valve more. And the question is, how comfortable would you feel if there were severe subvalvular caudal calcifications with tight room for grasping a flail leaflet? Would this make any difference to what you just showed?
I don't think so. I think if anything, I mean, it's not the chords you can see that you interact with. It's the chords you can't see. I think those chords, the calcified chords, are more likely to bounce off. It's the little thin ones that you probably become entangled with, and you can certainly become entangled on either side. So I don't know what
with anything under the valve, whether it's pacing leads, cords, whatever it happens to be, if you know you can elongate, you're fairly relaxed about.
Personally, the elongation is probably the most important feature of this device, and it's a unique feature, and it's very important because that we've all been there when you've been stuck and you have to deploy your implant somewhere that you don't want to because you cannot get it out.
So I think we agree that the calcification doesn't increase the risk of getting entangled.
I don't think so personally, no.
So I'm just going to briefly take us through the outcome of our case. So we approached this obviously with the PASCAL Precision, starting with the first ACE implant, anteroceptally, as you see there in the grasping views on the left-hand panel, and then quite pleasing coming in of the leaflets on the transgastric views. That was a good first implant from our point of view, and so we essentially proceeded to zip the valve up, so placing a second ACE aligned in the same orientation to the first implant, and then deploying that posterior to the first implant. And then finishing off with a third, so that there's a little trio of them lined up. And so with this, the baseline right atrial pressure V-wave of 21 came down to 12. There was a mean right atrial pressure reduction from 13 to 9. And we reduced torrential tricuspid regurgitation down to moderate on quantitative assessment with a mean tricuspid valve gradient of 1. This patient remains asymptomatic at 3-month follow-up. Her previous ankle swelling has resolved, and there is stable, moderate tricuspid regurgitation on follow-up echo. Thank you.
Thank you. Wonderful. I think you just have to get used to seeing colour at the end of the procedure. If you're looking for no colour in tricuspid cases, you're in the wrong game.
Well, the trick is to put before and after next to each other, then you get a real understanding of what you've achieved.
The 3D vena contractor is so important. And when you see that you've reduced the vena contractor by 50%, you know that this patient will have symptomatic benefit. And actually, this lady is asymptomatic. She's walking up and down. She's doing things she hasn't been able to do for years.
The response is really profound.
It's amazing. It's amazing, which is why we don't get too worried about a little leak between the two implants.
So we'll change over to Miriam and David. And while we change over, I see we've got a number of experienced tier operators over here. Just someone who is happy to talk about this. How often do you elongate in your day-to-day practice? How often do you find that you do that? Anyone happy to volunteer an opinion?
I think it's quite common, is the honest answer. I think if you're probably not elongating regularly, you're probably you should be doing it, because often you're trying to get into difficult positions and so on and so forth, and therefore making sure that you get in there and you're precise with where you want to aim for. Often you do get entangled, and so it's probably a critical phase. We must do it at least 2 or 3 times with every case, I imagine.
And if you're interacting, have a low threshold to elongate, because you won't get a good result with that.
Absolutely.
Great. Well, on to the next part of our session. So Miriam and Dabbit have another scenario for us. So what have you got to show us?
Thank you very much. So we would like to share with you some data and a case on another feature of the device, which is the atraumatic clasping. And for that, I would like to invite you all to dive right into a procedural case with me. So we saw this 81-year-old female patient presenting with multivalvular heart disease. She had a degenerated aortic valve prosthesis, but moderate stenosis, presented with this moderate to severe primary MR and also massive tricuspid regurgitation. And we decided in an after-heart team discussion to go for a concomitant mitral and tricuspid TEER procedure, not expecting, honestly, much of a complicated or challenging procedure. So looking first at the mitral side, we see in the left part of the slide these thickened and a little bit calcified leaflets. But we decided to go for A2P2 strategy, and since it was not a huge valve, we decided to first aim for a one-device strategy in this patient. And so in this position, we tried one attempt, still a large amount of residual MR. We tried a second time, and we also tried a third time, but still there was so much residual MR that we decided, okay, we have to change the strategy here. And after reviewing the 3D images, we saw that there was a quite large indentation in the posterior leaflet. So we decided to change to a lateral implant placement, just commissural and lateral of this indentation. And also here, we tried once, twice, and 3 times until we got a satisfactory reduction of the MR. And it was clear at that point that we had to go for a second implant in this case. And so we placed another ACE device, again aiming for this A2P2 position. So this was already the 4th clasping attempt, and always with full closure of the device, I have to add, in this position. But there we saw that we are rather opening up the indentation, so we decided to go very near to the first device and to close the indentation here as good as possible, leaving this grade 1 to 2 MR and a good transmitral gradient. So after 2.5 already quite exhausting hours, we thought, okay, we promised this lady that she will only undergo 1 procedure, so we have to do the tricuspid as well. And so we pulled back the system to the RA, which is the beauty of it, that we can treat the both valves with the same system. And we expected this to go very straightforward with an anteroseptal device, possibly 2. And so we did the first attempt here, and we already thought, okay, this is not as expected. The anterior leaflet was pretty long in that area. And what you can see very nicely in this video of the 3rd attempt, what we experience in the others as well, is this very high mobility still remaining of the anterior leaflet. But after the 4th time, finally, we made it also on the tricuspid. We put a second device in, also anteroseptally, with a very nice reduction of the regurgitation. So to sum up this case, and that is exactly the point of this part of the presentation, we had in total 7 leaflet catches with really full closure of the device on the mitral side, and also 4 leaflet catcher attempts on the tricuspid side. And of course, we know that the PASCAL system is supposedly designed to allow exactly this: multiple grasping attempts, leaflet optimization, repositioning, etc. But as interventional cardiologists, we do not want to believe, we want to know. And so, David, can you tell us, is there any scientific data for this?
So thank you, Meridian. I think your case is, you can keep your micro. I think your case reveals one of the most remarkable features of the device, of the PASCAL device, that is the safety. I think safety, it's a really important issue. I think the primum non nocere effect, it's really important. So we have to go through the procedure, assuring that we won't have any issue during the implant of the device. Probably this safety is because of the way that the device treats gently the leaflets of the valve, and probably it's related to the design of the device itself. You know that it has a single row of retention elements, and it has a spring-like closure system that conforms perfectly with the anatomy of the valve. So you can see the device moving all together with the heart beating, and you can see that this way the leaflets for sure won't get damaged. But I think it's important going moreover, over the marketing thing. I think it's really important to show some data, and this was the reason why a small study was performed by the CVPath, where it tried to evaluate the impact of the multiple clasping and the closing attempts, and the impact of the leaflet integrity. So to analyze if after we try several times clasping the valve, we have any sort of damage on the leaflets. And with this aim, it was a small study was designed, an in vitro study with a cadaveric model, taking the heart, analyzing both mitral and tricuspid valves, analyzing both systems, PASCAL and PASCAL Ace, and trying to analyze the different damage of the leaflets. And you will see it in a small video that explains this much better, that you can...
Edwards has partnered with CVPath Institute to evaluate the impact of multiple grasping attempts and optimizations upon leaflet tissue. To simulate tissue conditions and interaction in an in vivo situation, unfixed cadaver hearts were chosen for this study. Open atria, exposed to tricuspid and mitral valves, are then subdivided into a control side and an experimental side for both. A pump is used for forward pressure in the ventricle to ensure leaflet insertion and ease of capture for the user. The valves were divided into two parts, the experimental side and the control side. The experimental side with a high grasp number of 15 grasps, that is, clasps down, open, and close. And the control side, a maximum of 2 grasps, similar to clinical practice. Clasps are dropped to verify full leaflet capture, and then the implant is closed. This establishes one full run of capture and close. CVPath developed a grading scale of tissue damage as well as surface roughening. With no available standards of clinically relevant injury, their expertise played into creating a scale from 0 to 4 for roughening of the surface and 0 to 5 on leaflet damage.
So the results were pretty predictable, because what we see is that the device behaves in a really safe manner. You can see these are the microscopic images of the valve. The control side has a couple of small graspings there. There are some small imprints of the device, but no real damage of the leaflet. If you go to the control, you can see more of that, but no real damage of the leaflet. And if you go to the tricuspid side, this looks even better. So if you go to the numbers, you can see the gross leaflet damage, the amount of damage to the leaflet, it was below 2.5, that this is far away for what is considered clinical relevant injury. And it happens the same in the tricuspid side. Moreover, when we compare both devices, PASCAL Ace to the PASCAL P10 device, you can see that both of them, despite they have a different design, they behave in a really, really safe manner. So I have to say that I'm going to show now a case that we already knew this data. So we knew already about the safety of the device, and probably this had an impact in our clinical decision. This is a P1 prolapse case. You can see the 3D images here, pre-commissural prolapsing, not really wide. It didn't look a bad case. It's true that it's really commissural. You can see the jet going up, eccentric, going toward the septal wall. And here we are doing our first attempt. And the truth is that we have a good alignment. We are really coaxial to both leaflets. We are getting a lot of tissue. You can see both clasps going up and down. So these are good signs that we're in the right spot. But the truth is that when we close the device, at the end, we can see that there is still some residual jet that, despite its consider that it's mild, or you can see that it's really eccentric, and we don't like it because we were concerned that once we release the device, it wouldn't look good. So we decided to change the strategy. The feeling with the first clasping was that we're missing part of the prolapse, so we thought that we need to go more commissural, so we release a little bit the system, we take some of the flex out, and we try to go a bit more commissural. The truth is that here you can see probably the second clasping is a bit too ventricular, so when we close the device, there is some bouncing of the posterior leaflet, so we can already predict that this is not gonna look perfect. So we put the color on there, and you can see that it looks even worse than the first one. But we are really stubborn, and we love to get perfect result in these cases, because we know that if you don't fix the whole prolapse, it won't look good after that. So we tried several attempts, different angles, and in the 10th option, we really got a lot of tissue. You can see both clasps moving up and down, and now the posterior leaflet looks more stable, and the residual JIT looks small. We thought it was related to the tension, but when it was released, we realized that we couldn't see this so commissural yet, and despite it wasn't really important, now it looks worse, and it looks really eccentric, so we were concerned that this can increase in the future. So since we were playing a safe game, we knew that we have a lot of tissue in the first device. We thought that we were able to fix that despite it was completely commissural. So we went just slowly, changing the angle, pushing all the system in, getting more flex, and we find the spot anteriorly where the device gets in. Once we are in, it's easier because we are just below the valve. We have a lot of tissue there. You will see we'll open the device slowly. So because we don't want to push the other one, we don't want to push the chorda either. And once we open the device, you can see that both leaflets are inside. We tried to move a bit more posterior because we thought that the mechanism was mostly that we're missing part of the prolapse. And once we got there, we closed completely fully the device, and you will see that the color improves dramatically, and there is not even a trace of color at that part of the commissure. So this shows how safe it is to play with this device. And the thing is that we analyze it now even better. We put some color there. You will see that the device is still on site, it's holding, but we put the color there and it looks pretty good. There is trace, but more towards A2P2. And once we release, the result looks even perfect. So the summary of that is that in this data that we got from the in vitro studies that show us that we can play safe, that we can do a lot of claspings, that this improves a lot of our results, that we can really try several times to achieve the perfect result with our device. Thank you.
Well, that's a great case. Thanks for that. I haven't seen that one before, so that was very impressive. And illustrating a couple of points. One is the safety of making multiple grafts, but the other one is that you really can go that commissural with this device because you can elongate, you won't get stuck, and you really can get through a very, very small space to get the perfect result.
I think we always talk about devices, but the imaging is the other key to improve your procedure. So in this case, I think the path was clearly shown. That's what makes the difference.
Thank you very much.
See you.
So I think a really important point that we'd like to look at now is predictability. Now, something we've noticed in the cath lab is that you make your grasp and you're happy with it, and then you release. And with this device, we've very often noticed that it's the same after release or it's a little better after release. And we have thought that for a while, but it's much better to know than to think. And so Peter has done a lot of work on this. So Nicholas and Peter, let's hear your case.
Yeah, well, thank you very much. And we will dive right into the next clinical case presentation, which we thought is a case that nicely demonstrates actually the importance of pre-post release predictability when performing MTIR. And it's a case of a 77-year-old male patient with worsening dyspnea, NYHA class 3, otherwise in a very good physical shape, no decompensation or hospitalization for heart failure symptoms. The patient had permanent AFib and was anticoagulated with edoxabane and had a history of coronary artery disease, which was well managed by PCI, and also some peripheral and cerebral vascular disease, which had been treated by the vascular surgeons up front. And we see on TTE, it's a patient with really severe primary mitral regurgitation due to a P2 prolapse with a flail. Although the valve is nicely opening, we have an increased gradient, which we sometimes have as a pseudo-high gradient in patients with very severe MR. LV ejection fraction was preserved, a little bit mildly reduced RV function, but otherwise no concomitant valve disease. And looking at the TOE of this patient, we nicely see on the left side the large flow convergence zone below the complete P2 segment, and on the right image by scrolling with the X-plane cursor through the P2 segment, you can appreciate the P2 prolapse and here the flail. And this resulted, as you nicely see, in a really massive primary MR, again, the elevated gradient. So we discussed this case in our local heart team, and the patient appeared for us at an intermediate surgical risk. So surgery would have been an option for the patient, so mitral valve repair. But the patient refused actually open heart surgery, so we consented the patient for mitral valve transcatheter edge-to-edge repair. And our procedural strategy in this case was a two-device implantation strategy upfront to really completely eliminate the P2 prolapse and flail. And for that, our plan was to implant the first PASCAL ACE device on the medial aspect of the P2 segment without any residual MR on the medial side. And then as a second step on the lateral side, another ACE device without any residual MR on the lateral side or between two devices. So in summary, it's an intermediate surgical risk patients. Surgery would have been an option. We need an optimal surgical-like result, meaning MR 1 plus or less and gradient below 5 in that patient, rather complex but empty or suitable anatomy. And of course, with the two-device implantation strategy, this requires a high pre-post release predictability to achieve an optimal result. And with this, I will hand over to Peter, who will demonstrate.
Yes, also a warm welcome from my side. And before I show you the deploy or release mechanism in the wet lab model, as Sam introduced, it's important that we know what we are actually talking about when we talk about predictability, especially in patients where we have a small valve opening area, high gradients, calcifications, where it might be that we have not the opportunity to put a second device. There is this moment within the procedure where we need to rely on what we see in the echo. When we did the approximation of the leaflets with every given edge-to-edge device, we need to rely on that when we pass the point of no return, when we release the device, that this result remains stable and acceptable after we release the device. It's quite difficult to assess the residual MR after an edge-to-edge repair. There's a comprehensive recommendation of the American Echo Society, which is not so feasible within the procedure as we learned, but there are some aspects which can be easily assessed. And this is something what we did when we started back in 2019, starting to treat patients with an edge-to-edge repair, with a PASCAL edge-to-edge repair device. And what we learned when we compared our early experience with this device, with our previous experience with the second generation MitraClip device, we learned that with both devices, we have patients where after releasing the device from the steering catheter, there is a deterioration of the result we saw before releasing it. This was quite rare with the PASCAL device, and what we are conducting at the moment and still enrolling is a precision registry where we want to try to understand if there is a specific given anatomy beyond DMR, FMR, and mixed that is prone to provoke such kind of a deterioration. What we see in this very early stage of this registry is that we treat most of the time very complex and non-co-opt anatomies, most of the time mixed or DMR anatomies. And what we see at this very early time point is that it's quite a rare event. But as I said at the very beginning, it's important because we have patients where we have not the option for a second device, and when you end up with a suboptimal result because of a deterioration after release, then it's a disaster for such patients. And what I will show you now at this model here, we have a perfectly aligned device. You see the leaflets are already on. It's not live, I think. But it's nearly the same image. You can see that I will focus on the deploy mechanism to show you or to give a kind of an explanation why these results are so stable. And what you can see here, we have the leaflets nicely on the PASCAL. I try to attach them a little bit more. Then I pull down the clasp. See, it's bouncing a little bit. What is a typical sign that the leaflet is beneath the clasp, and then we close the device. The device shortens, so we have to release a little bit of tension. And now is the moment when we regularly check for reduction of MR. We check, is there a new jet? Is there some eccentricity? And this is the moment where we must be sure that everything stays like before when we release this device. And this is what we test now. Hopefully it stays stable. So you have to release the sutures. You have to fix the device, release the sutures. In real life, you do this under permanent echo control.
And this is the moment where you're thinking, what's it going to be like after release? And what we want is a stable result. We don't want any surprises. And with the case Niklas showed early on, where there's a lot of redundant tissue, you worry about movement. But actually what we see is that generally you get a very stable result on release.
In former times, we called this moment the moment of truth. So then you have to release the pin. And even if you have some bowing in the steering catheter, we learned that even this bowing does not affect the predictability aspect of this device. So I have no fluoro here, unfortunately. But you see now.
Yeah, so you can see it very nicely on the boroscope on the left there.
So the device is deployed and there is no alteration of the regurg signal. It's even a little bit better, and this is something what we also regularly see, that it's the opposite of what we expect, that it becomes even better because there is some kind of a centralization of the device. And the reason for this this predictability might be that the detachment mechanism is from the atrium. So the lever arm is very, very short, and we have not so much tension within the valve and the device. And I think when there are no questions at this time point, I hand over to Niklas again.
Well, thank you. And maybe you can show the presentation, the PowerPoint presentation again. So this is then how we treated the case. And as planned, we went for the medial aspect of the A2, P2 segment with a 12-6 orientation. You see here the grasping or clasping of the anterior leaflet. We always do that, almost always do that separately, even not performing the Tarzan maneuver, but concentrating first on the anterior leaflet, then on the posterior leaflet you see on the lower right side. And that was the result after the first grasp. So you see already a very nice reduction of MR, probably to mild on the lateral side. No MR, residual MR on the medial side. So after a thorough assessment, we decided to release the device. And you see here in the middle part, we had some tension actually on the catheter. So the catheter jumps a little bit from the device, probably because we have a lot of movement also in the leaflets due to the prolapse, and that was then the result after release of the first device. So maybe even a little bit improvement, and with actually no relevant MR on the lateral side, but still you see it on the in the 3D images on the lower right side. There is still residual prolapse. So this is a region prone for recurrent MR, and if we really want a durable result, we decided to treat this as planned up front. So we went for a second device, oriented the device laterally to the first one, again grasping the anterior leaflet you see here, and then the posterior leaflet, and then closing the device. And we had probably the same amount of residual MR coming a little bit from between and a little bit from the lateral side, but we still had some tension on the catheter, and we had a very nice leaflet insertion. We didn't see anything left of the prolapse, so we went for that device. And you see during the release mechanism, we released a little bit of the tension, and there was a release without jumping off the catheter, and then we had the final result here with really trace MR and a completely eliminated P2 prolapse. And again, this is the final result. On the left side, the TOE images, we actually reduced the gradient from 5 to 2, and then the final TTE discharge showed a stable result with the trace MR and a gradient of 3, so a surgical-like result in this case. Thanks.
Fantastic. So you've seen the data, you've seen a clinical case, and you've also seen it live. So I think that's a pretty good demonstration of the predictability of this system when it comes to device release. So Volker, have we got some questions, or should we ask the audience?
No, we don't. I mean, we should grasp the opportunity to ask the audience if anyone wants to share their experience with this particular feature of the device. And I mean, do you have any case you would want to like to share where you experience problems? May I throw it?
Yeah. Okay. Thank you. So just back to the case where you had to add a device in the commissure. In the US, what we are approved for is DMR, and what we have access to from an FMR and TR standpoint is obviously through the clinical trial. So I just wonder, going into these tighter segments, it was demonstrated very nicely with the device being closed, that entering in that tight space is fine. But I just wonder, can you enter elongated and then start forming the device right underneath the leaflet to capture? Any experience on that from Europe?
It's a very good point. I don't know if someone wants to take it. So I think Niklas, just go ahead.
Actually, I always travel towards the LV elongated and then get back into capture ready. So I'm not traveling close, but elongated. And from my experience, you always have the leaflets on the device then. You have less entanglement with the first interaction with the leaflets with the cords. So I like that very much.
And especially you don't overcome resistance from cords that shouldn't be in the way when you close it from an elongated position. So I think this is a preferred way to do it in a very commercial anatomy.
So some good questions there and good discussion. Now it's over to Becky and Volker. This is going to be an exciting part of the session. We've got 20 minutes, and they've got an EVOQUE device, and we're going to see what they can do. So Becky, Volker. I'm
just going to comment a little on our experience with the PASCAL and the the regurgitation on release, and I think in part it's related to the release of the device from the top versus the release from the bottom of the device, right? So the other device that we use releases from the bottom, and so you end up having more tension, I think, on the leaflets than when you release from the bottom, and it releases like that. Versus what we have with PASCAL, which is that it releases from the top. Remember, it's a nitinol, it's a beautiful nitinol thing, and it's actually hooked to the very top of the device. And so what you see is what you get, is what we found, which is a really nice feature of that device.
Yeah, very good point.
And I suppose because it's a little bit more flexible, you're less likely to build up tension unintentionally.
Yes, exactly.
But I've now eaten into 3 minutes of your time. So,
Yeah, sorry. Okay.
so why don't you present?
But Volker's got it.
Maybe we start with the case,
Yes,
and then we go to our model. Can we see this? Brought you some data from the recently published TRISCEND 2 trial, and as you might be aware, this was a trial that was randomized. It included 150 patients, the first cohort, randomized in a 2-to-1 fashion, and as of now we have the 6-month results available. And the only thing I want to share, and this is of course what we want to highlight here, is that I think with no other approach you will get an equally effective reduction of TR as compared to with a prosthetic valve. And I think this is what we want to show you. And I brought you a patient that we treated with this device. She was an 80-year-old female patient, rather normal weight. She had a history of 2 prior heart failure hospitalization before she presented to our hospital. Coronary artery disease was ruled out. She had preserved LV function, had a dual chamber pacemaker, which plays a role, had amiodarone-induced lung fibrosis because she had long-standing atrial fibrillation, and some other comorbidities, including an MGUS with IgG lambda, which might play a role, of course, in these patients, as I will also highlight later. These were her drugs. There's nothing remarkable so far. Her hemodynamics, always important, but as you can see, she did not have, she had post-capillary pulmonary hypertension, but no pre-capillary pulmonary hypertension. So pulmonary vascular resistance was low, and but she had a high pulmonary capillary wedge pressure. Although this was after recompensation when we did the assessment. Those are her lab values. You see anemia, you see impaired renal function, preserved hepatic function, or no index of hepatic damage, and an increased NT-proBNP. Those are her scores. So she was high risk for surgery, certainly. And this is already her TTE from screening after recompensation. So you can see that this pacemaker lead has an interaction on the left side with the septal leaflet in the somewhat anterior portion here, and as you will be able to appreciate, this is really torrential tricuspid regurgitation. You can also see the huge gap already here, and importantly, we could rule out amyloidosis in this patient, which I think is important in a case as this one with regard to prognosis. Here you can see the screening TOE, and you can see on the left panel that there was also a remarkable gap in the more central region of the valve, which was not related to the pacemaker lead. Here, the gap that can really be appreciated, and of course also here the torrential TR with the measurements on top. And in the transgastric view, you can see that we really had a strong interaction with a pacemaker lead in the anterior region here. You can see this here in the transgastric view, but also nicely in the 3D image, which I think it's uncommon. Most commonly, these leads are in the posterior region, and we're more, we're more used to deal with them in this region here. Together with a maximal gap size of 12 millimeters, we thought this would not be a very good case for TEER, and therefore we decided to try and implant a valve in this patient. And I think with that, I can directly move over to the model that was set up here. So some explanations on the model. First off, this is a pig heart, and as you can see, we don't have a vena cava, we don't have an atrium, so it's not the real thing. And I think Becky will highlight that the valve is also not the real thing. So there are some deviations from what we see in human pathologies, and I think we can nicely see this in the echo later.
If you want to show the boroscope, we could show it really quickly. I mean, normally we have a nice, in the setting of torrential tricuspid regurgitation, we end up having a more circular annulus, so it becomes very circularized. This is still very D-shaped, And in that setting, the AP commissure is 5.7 centimeters. We measured it, which is obviously not, it's very, very large, and then much more narrow in the septolateral. But this is not what we would see, obviously, in a patient with torrential TR.
So a really challenging case.
And get that in first, right?
Yeah. So, and maybe I can also point out some things about the device. So if we go to the front of the device, there's a flexible taper tip, which now I think we can't see. It's in the ventricle, but it's designed to be really atraumatic. And then as we move upwards, there's a capsule. And within this capsule, which we can retract, there is the valve prosthesis. The valve comes in 3 different sizes, 48, 50, and 52 millimeters. And it's a nitinol frame, basically, which has 9 anchors. The anchors are also atraumatic, and you need them, of course, for anchoring. But for this valve, you also need oversizing. So you need the radial pressure to fixate this valve. And the valve has also a skirt around it. So if we move now to the upper part, I think one thing that's really important to mention is the sheath that we have here. So this is not a steerable sheath, it's a normal sheath. It has only 28 French, which is something that has to be pointed out for a valve prosthesis, I think. And then when we move to this part, we have more or less one catheter here, a bit different to what we are used from PASCAL. And then we have this first section here, which is for valve release. So we have 2 knobs for valve release. And then if we move to the back, this is for valve positioning. So this is where we can steer our catheter. And I want to briefly walk you through to all the knobs that we have here. So we have one knob here, which is for primary flex. So this is the movement where you move down to the tricuspid valve. Then we have a secondary flex, which is 90 degrees offset to this first flex. So what it does, it moves you away from the septum. So if you're close to the septum, you can give secondary flex, and then it moves you away to avoid this hugging situation.
So for PASCAL users, just to orientate them, this is akin to steerable, and that's akin to guide flex, right?
Yeah, exactly. But the only difference that you can't move them between each other. So, and then we have another knob here, which helps us to gain depth or to lose depth. And here we have an element where we can steer the flexible nose cone, which you can push in, push out. And we also, but we should not overdo this, we can also use the wire to gain or lose height. Obviously, if you push in too hard, this could be traumatic for the right ventricle. And then the basic movements are very familiar to all of those who do TEER. So we have the opportunity to move this device in and out, and this is done in a very controlled way. So I have a knob here where I can move the device in and also out. So it's not done by pushing and pulling. And of course, so this will do an anterior, posterior movement. And then by releasing this knob here, I have the ability to, of course, rotate the device in a septal or lateral direction, as I think everyone is familiar. So now we have the device already positioned, and it's very important. I think, Becky, you will best comment on this, what we have to look for here.
So for this particular device, we're heavily using multiplanar reconstruction because, again, it's the ideal way to maneuver and to ensure trajectory is to be able to see the short axis 3D view that you see here. And we have the green plane aligned in the anterior-posterior direction, the red line aligned along the septolateral direction. And we can always orient this the same way every case, no matter where we acquire the image from. We are acquiring currently from an inflow-outflow view, so our tricuspid commissural view, which makes it the easiest to orient in this way. So then when you're looking at the green plane, we're going across from left to right, is going to be posterior to anterior. And then in the red plane, it's septal to lateral. And so as long as we align it the same way every time, no matter where I acquire the image from, so it'll be different if this is acquired at about anywhere from 60 to 90 degree mechanical rotation. But if I acquired it at 130, I just rotate everything around to get it to the same view for the interventionalist. So that
make it easy for.
Yes, so the communication is very clear.
Yeah.
When you move it anterior, so you're a little bit posterior now within the annulus, you see very, very slightly.
Mm-hmm.
Then when you move anterior, it should move anterior,
yeah.
which will be toward 5 o'clock.
So maybe we can do this right now.
Sure.
So I will do nothing else than turn this knob here.
Yeah, and I'll keep the crosshairs for now. But you'll see his device move off my crosshairs because he is moving anterior. So that was perfect. Yeah. All right, so now I'm going to just reset my crosshairs so that I'm on top of the device. And it's very easy to do, obviously, using multiplanar reconstruction. So I can, with a click of a button, put the crosshairs anywhere I want. And you can just see it's very, very easy. And so I'm just going to realign myself with his device. And this way we can keep track of him throughout the procedure. He's moving, I can move also and make sure that I see his device in 2 planes so that we can, at least 2, we can rotate around in order to assure that the trajectory is correct.
And we should say that this is the point where we always do a timeout during the procedure. So this is the point where we could still remove the system. When we continue now, we cannot no longer remove the system. So now we have to be sure that this assessment is proper and that we are confident that we can place the valve. So I think, for the sake of time, we have to start the deployment. So I will now rotate this white knob here clockwise, and you will see on the echo, and it's a bit harder to see on the boroscope, the anchors of the device coming out as I am retracting the capsule, and I will try to move them out so that we are at about 90 degrees.
Yeah, and so on the echo, very easy to see. So we're now at 90 degrees, very easy to see. I've put the blue plane right on the anchor. It's 90-degree anchors. So I've put them right on the anchors. And so sometimes there's a little bit of bunching of the anchors, but there are 9 anchors that we want to be able to identify. So you'll see a little bit of bunching can occur at this particular stage. That doesn't bother us. But what we want to now assure him is that the leaflets, that he's cleared the papillae muscle so that he's not too deep, but that he's deep enough that the leaflets are coming above. And so with this particular model, we know that the anterior leaflet is super long. And so we may have to go a little bit deep. The other thing we know about this model is because it's a normal pig heart, it's saddle-shaped. So just like the mitral annulus, the tricuspid annulus is saddle-shaped, but it becomes much flatter when we have tricuspid regurgitation. But this is a normal one. So you're going to see that we'll be a little bit off the annulus on the septolateral side, because that's going to be the high part of the saddle, and we'll be correct on the anterior posterior side, because that's the low part of the saddle. So
I already moved in a little to the ventricle, and I think we see now a little posterior trajectory, if I'm not mistaken.
Yes, and so I can realign, and you see I'm realigning my green plane. It's very, very easy to do with the controls here. So you can see me rotating my red plane, but I'm going to align it with the device, which means now my blue plane, again, is on top of the anchors. And so the beauty of that is you can, again, look at the short axis view and see the leaflets coming toward the inside of the device.
So we want to make sure the leaflets the anchors are outside the leaflets, right? Or on between the leaflets and the ventricular wall.
So would you agree to give up a little bit of primary flex, Becky?
Yes, that would be great.
So now, as I do this, you will see that the valve tilts anterior. So we will gain height anterior, and we will lose height posterior. And we hope to come under this anterior leaflet, as Sam pointed out. We'll move in a little more. And I think now we can go on and release more of the valve. And
so
hope
you can
that
already see, I mean, I haven't moved, that the tip of the anterior leaflet, it now comes above and is now coming well into the center of the orifice and above the anchors. Now we're positioned, so typically when we're speaking to each other, we'll talk about position and trajectory. So they're two different things. And so in this particular case, he is positioned ever so slightly anterior. Now just remember that this is a 57 millimeter anterior posterior annulus. So to get it perfectly right is going to be tough for the device. But just a little bit of an and he's already maybe corrected a little bit with a very, very slight posterior trajectory. But that's okay because, again, we need to be under that long anterior leaflet. So very, very, I mean, just beautifully shown here.
I'm just watching Volker's hands here. He's moved the depth a little bit, and he's also used the wire to just change the height in the ventricle.
Exactly. So we try to get deep enough in there, yeah.
And as you continue to deploy, do you mind just describing to people not familiar with this device what the anchors are actually doing? What is happening?
Yeah. So as we move on now, you will see that the anchors flip at one point. So they
start to come back up towards the atrium, right?
They come to
the one thing we'll do for him very quickly is make this rotation, right? So you see in the short axis view blue plane that I can rotate and see every anchor. And so just before he flips, we'll do that very quickly. And then after he flips, we'll reposition ourselves at the tips of the anchors. So you see the 9 anchors in the short axis view. And that way we can use multiplanar reconstruction to look at every single anchor and the leaflets above every single anchor. And that's really important for us. So again, so we'll go ahead and try and rotate around. And usually what we'll do is we'll all decide between us which box and which side of the box we're going to look at. Because if we're looking at different things, and then we can't communicate well. So usually at this point, we'll use the green box, right side of the green box. So the right side of the green box is going to be over in the anterior. And remember, we're going to have to deal with a little bit of the commissures. And the anchors can be inside the commissure, within a commissure, and we can still capture around it, even if we have capture of the other anchors. So we're going to move around, and we're just going to continue to go around. You guys all look and see. Do you see leaflet above? I say yes.
Yeah. So Becky's rolling through anchor by anchor, and what we're doing is making sure that the leaflet is above each anchor, because then you know that you'll get a stable result.
Yeah, so we're again just trying to stay in the center of our device, but rotating on each anchor. So here's another anchor. And again, leaflet seems to be coming in the middle. Here's another anchor now. Again, we're just concentrating. And this is a shorter anchor, a shorter leaflet on this side, which seems to still be, we're a little bit in... It's a little bit along the septal commissure, so we just have to be a little careful of that. And then we continue to go around, and all the other leaflets seem to be okay. As we get bigger, we might be able to see more. I might go in 1 millimeter just to be sure that we're going to capture in the APV.
So I rotate here on the depth knob. You might see that we dive into the ventricle here.
I'm just going to try and get back into the view.
So I suppose as they continue with the deployment, I don't want to lose all our interaction and discussion time. So does anyone have any comments or questions? Anything they'd like to raise? Just raise a hand. We can give you a microphone. And I suppose one thing that's worth thinking about, and we'll have a look at the case we saw a second ago on the presentation, is which patients can't we offer edge-to-edge repair to, and it's exactly that kind of anatomy. So we often see patients with pacing leads. Mostly they can be treated with edge-to-edge repair, but if the pacing lead is actually splinting the valve open, then you can't really treat with edge-to-edge repair. It's also those patients with massive coaptation gaps, which should be on the reach of edge-to-edge repair. So those are the main groups that we can't really treat with TEER. And I suppose worth asking, we're a room full of TEER enthusiasts, and we're treating people with tricuspid TEER. Can someone give me an idea in their practice what proportion of patients or how many patients they have around tricuspid patients who you just can't offer TEER? We don't have a technology available to them now. Anyone like to give me some comments on that? People with severe TR, which is beyond the reach of TEER?
Thanks, Sam. I think I would say, as many as 30%, 40% patients may be unsuitable for one or other reasons. Imaging, at the moment, we're relying very heavily on screening echoes to make sure that we can offer them this treatment. You mentioned pacing wire. They are pacing wire which are pinning the leaflet all the way to the septum. Yes, if they are in the commissure, you could offer them TEER, but if they're not.
Yeah, so pacing wire moving freely, probably fine. Pacing wire splinting a leaflet open, probably not fine.
And very rarely, I guess, it's a clinical decision, because if you think that their disease is so far advanced that even if you were to offer them TEER with some reduction in TR, this is not what they need. They need better resolution of their TR to really make a difference. Yeah. And that's where I think the valve replacement sit for me.
Yeah. It's been CE marked for a couple of weeks now, and a really important addition to our armamentarium. How are we getting on here?
Yeah, we expanded the ventricular section more with the white knob, and we're now moving a little bit up to the valve as our prosthesis has gotten bigger, as you might appreciate. Yeah. You see that we are now in the left upper hand image. We're a little anterior, so I can correct this by pulling out the device with this knob here. Now we're more central again. And Becky, if you agree, I would...
Yes.
So we'll let Volker and Becky continue, but do wave at me if you have any questions you have for any of the panel, or if you have anything that you'd like to ask Volker or Becky as we go through this.
Sorry. So what we're looking for is, again, is if you look in the short axis view now, the green plane, you can see the leaflets coming in toward the center of the device, and that's another clue that the leaflets are coming up and over. And so this is for us a really good sign. Remember, this is a very atypical valve because it's very, very long AP. And so those commissures are going to be a little tough to capture. But again, if we do our rotation here, so I'm just going to, you guys stare at one side, one corner, and we'll just, because I'm in the middle, and we'll just go around and try and make sure that leaflets look like they're coming into the center of the device and up and over the leaflets. So again, not typical for us given the size of the AP annulus, but again, we see pretty well leaflets all the way around. So again, I think that he's in a good spot, and we could, we could possibly go for full deployment.
So what I will do next is turn the white knob till we get full ventricular expansion. Which I think we reached now. And then I would directly, for the sake of time, continue with the atrial expansion. So I will pull back the nose cone. It's something you can't see now in the valve. And then I will use the blue knob now to get atrial expansion and also to finally release the valve from the catheter, which happened now, as you can see. So now I'm reaching a hard end here, and so
again, you can really see very nicely in the short axis. It's just a beautifully positioned. It didn't move at all, right, during deployment, and the final release, it just stays very stable like that when you're in the right position. And this is in a beautiful position. And then you can see that he's trying to retract the nose cone. And so we stay on a three-dimensional image so that he can see if he's anterior, posterior, septolateral, to get himself in the middle so as not to disturb the new valve. But this is just
two plaques there.
Beautiful. This is a really nice example.
So you always
He's
have
an
to...
expert. I'm going to let him do mine.
Very nice. What a team. Very cool. Nicely done. A beautiful demonstration of the EVOQUE technology and of the interaction between the imager and the operator and how MPR really makes it possible, rolling through anchor by anchor to make sure you're in the right position. So very nice. Thank you very much.
Well, thank you.
So should we have a look at your resolution?
Let's finish the case. So this will just recapitulate what we did now. So here you can see the valve actually. CT screening is of course of importance. We have had a perimeter-derived diameter of the valve which was 49 in diastole, 48 in systole. So we chose a 52 millimeter valve in order to have oversizing, in order to have radial fixation of the valve. And this is already in the procedure. Capsule gap is created. We had alignment of the catheter, and so we moved on to open the valve. This is how it looks in fluoroscopy. We go to 90 degrees, and then we do the spin around to ensure that leaflets are engaged. And then full ventricular expansion looks like this in fluoroscopy. And then this is the complete expansion. Now you see that here we retract the taper tip to have it at the height of the prosthesis, which has been done now. And then you get to full atrial expansion and to release of the valve. We will see in a second that it pops open and that then it is actually functioning. This is how this looks in the echo, in the 3D echo. This is the final result with just a really tiny post-receptal paravalvular leakage, as you can appreciate in these two images. We already have the 1 year follow-up with this patient, so there were no further decompensations of her. The valve is fully functioning after 1 year. We have a gradient of 4 millimeters of mercury, and so it was, I think, a successful story in a patient that we would not have known how we would have treated her otherwise. So, well,
very nice.
Thank you very much, and hand over to you.
Great. Well, thank you very much, everyone, for joining us and for staying for this session. Some really great cases, great demonstrations. All the technology works, which is fantastic. So well done to everyone who is involved in putting this together. We've seen demonstrations of safety, predictability, and versatility of the PASCAL device. And we've also seen a beautiful demonstration now of the EVOQUE device. Thank you very much.